I'm excited to present a few slides to you today. We are actually living in perhaps the most exciting time in nephrology for preventing or slowing the progression of kidney disease. And new information is coming out in studies all the time on this topic. And so it's really titled it Modern Strategies to Reduce the Decline of Kidney Function, also known as reducing proteinuria, amongst other things. And just as a backgrounder to set the table, so to speak, you're all aware of kidney function as being defined by different categories of eGFR, and that's displayed on the left or the y-axis of this graphic. But also important is the x-axis, or albuminuria, or protein in the urine. So it's quite possible that somebody who has relatively good eGFR, or kidney function, actually is in a high risk category because they're spilling lots of protein or albumin into the urine. So one thing that we're looking closely at is to get people's ACR, albumin creatinine ratio, or UACR, monitored along with just the eGFR. And we can now identify through risk stratification equations just the patient's risk of kidney failure progression, and design treatment strategies appropriately. And so these are the hallmarks of how we do things in our kidney care clinics or in practice. We at the starting at the top, obviously we try to get people's blood pressure under control. This is either through improvements in weight, but also in terms of retaining sodium intake and water balance, and then achieving glycemic and metabolic control through diabetes management and lipid management. And then for the last 30 years, we've been employing strategies of ACE and ARBs, such as ramipril, candesartan, to blockade that pathway, which helps to lower the protein in the urine, also has an effect on blood pressure. Today, we're going to be discussing some of the newer agents, newer strategies, and that's the SGLT2, or the flozins, and the mineralocorticoid receptor antagonists. And obviously, a multidisciplinary team is important. Involves nurse, dietitian, social worker, pharmacist, and really, ideally, this is in treating patients upstream from when we ideally see them in a kidney care clinic. So really moving into primary care before referral to a nephrologist, ideally. Obviously, we measure regular blood work in the urine, ACR, albumin creatinine ratio, and then we regularly assess the patient for their level of education about their disease, help them navigate their resources required at each stage of their disease, and then surveillance both the patient and the population. Just a little note about salt. So, I think there's a misconception out there that, I might have a lot of salt in my diet, but I just drink water and I'll just pee out the salt. And episodically, that might be uh, something that does happen, but over time, and particularly with the North American diet, there's a number of pathophysiologic mechanisms that get triggered, leading to end organ damage. And this is in the heart, the kidneys, the brain, the stomach, the bones, and fat deposition. And the end result of these damaging effects include heart failure, myocardial infarction, stroke, dementia, chronic kidney disease, focus on this lecture, and stomach cancer, osteoporosis, kidney stones, which also can beget kidney disease, and then obesity. And just as an association for patients who have urinary sodium excretion of greater than 2.8 grams a day of sodium, there's actually a linear association of increased risk of composite renal outcomes for every 2.3 gram increase in sodium excretion. And why this is important: in the North American diet, it is not difficult to achieve a sodium intake of 5 to 10 grams of sodium a day. just given the amount of sodium that's put in our foodstuffs we buy in the grocery store, as well as restaurants where we eat, outside of any salt on the table that's added to our diet. So there's already a background elevated risk from the amount of sodium in our diet. And just to give you a sort of a climate perspective, climate change perspective on this, really the best practice optimal outcome is achieved at the lowest cost, the lowest environmental impact, and the most climate resilient, but also it's better for the patient, the best care. So it's starting at the top, health promotion, identifying patients who are at risk for kidney disease progression, early adoption of those lifestyle therapies, and then continuing on to provide them pharmacotherapy to slow the progression of kidney disease, and then getting to a point where renal replacement therapy might be considered, looking at transplantation or conservative care as appropriate. And then obviously dialysis is the most impactful to the climate of the therapies that we provide. So strategies to try to limit that. But where this talk fits in is in the red square there. So let's get on to the meat of it. So we've already discussed some lifestyle modifications, and to slow the progression of chronic kidney disease. As I mentioned, the last 25 years, we've been focused on ACE inhibitor and ARB use to block the angiotensin system, to reduce the protein in the urine, and to reduce blood pressure. In the last year or two, SGLT2 inhibitors have become standard of care for this population. And then we'll discuss the non-steroidal mineral receptor antagonists, as well as possibly supplanting or in an alternate to spironolactone. And then we'll touch on the GLP-1 receptor agonists and the endothelin-1 receptor antagonists. These two graphs date back to the turn of the century, where we had IDNT as a landmark trial using irbesartan against standard of therapy. And in the renal outcome, we've seen a risk reduction, and this was groundbreaking and practice changing. And also in the renal trial around the same time, losartan, an ACE inhibitor, demonstrated also a risk reduction. So either ACE or ARB became the cornerstone of therapy. And but you'll note that there is a residual risk somewhere between 20 and say 35% that is untouched, that there's still a risk of progression of kidney disease. And so that is the area of interest, to see if we can further reduce that residual risk. Just to put it in context of heart disease, so cardiovascular death or hospitalization due to heart failure, when we add an SGLT2 inhibitor, we do see a further reduction in standard of care, which would be ACE or ARB therapy. And that residual risk is in the range of 4.5 to 8% remaining. So it's about tackling that residual risk in additional strategies we might employ. Just to illustrate this further, if you take a patient in the green text in the upper right of the graphic, at age 63 years, EGFR is 56, and his projected decline of kidney function with ACE and ARB therapy would be about 4.6 mils per minute per year, which equates for him at the age of 73 at a point of EGFR 10, when we might entertain starting dialysis or some renal replacement therapy, transplantation. Contrast that to the same patient who not only is on ACE or ARB, but we've added, in this case, dapagliflozin as an SGLT2 inhibitor. His decline in kidney function is slowed to 1.85 mils per minute per year, so that by the time he reaches the EGFR of 10, he's now 88, and he may have other comorbidities competing, the renal disease, and he may elect conservative management, or he may certainly, if he elects to be on dialysis, his time on dialysis will be shorter. In fact, 15 years shorter. and that means a tremendous amount to the patient to be not on dialysis for that length of time, but also to the system. So publicly funded dialysis in Canada, that would represent $1.5 million Canadian. It also avoids to the environment that number of years of dialysis, about 60,000 kilograms of carbon emission avoided, which is roughly the equivalent of driving a car 250,000 kilometers. So you can see, this actually impacts all the important areas that we need to hit on. And so this is really an exciting time to be able to offer this to patients. Finerenone is a non-steroidal mineralocorticoid receptor antagonist, and this graphic is just a synopsis of all we know that it can impact. And in the middle, so spironolactone is what we have currently, and it does have some side effects of gynecomastia and serum potassium rises that may be problematic. But finerenone is non-steroidal, so avoids those sex-related side effects. But in the middle, you have the mineralocorticoid receptor, and aldosterone would bind to that, particularly, in the case of hyperglycemia. And so finerenone would bind to that, and all these signaling agents for fibrosis, inflammation, or creation of reactive oxidation species are somewhat halted or halted, which then leads to the next circle in mauve of all the potential things we would see as a result of this. And the outer circle are the things, the outcomes that matter: kidney failure, death from renal causes, myocardial infarction, hospitalization for heart failure, arrhythmia, etc. So finerenone, the magnitude of that residual risk that is reduced by finerenone, I think we still have to have studies to fully illustrate that, but we do know that there is the signal that it actually reduces that risk further. GLP-1 agonists is on everybody's mind, it seems. This is semaglutide as an example. They reduce inflammation, reduce albuminuria, and they, through weight loss and appetite regulation, help to regulate blood pressure and improve glucose control. And all of that provides a cardiovascular protection and slows kidney disease. So in the appropriate patient, these agents can be quite an addition, a powerful addition to slow the progression of kidney disease. Not yet on the market are the endothelin antagonists. And some of the, a couple of the names we may see, generic names, are atrasentan or zibotentan. There's a couple of others being studied out there, but there's a lot of factors in the upper left of the graphic: acidemia, aging, dyslipidemia, hypoxia, oxidative stress. All these things can result in increased endothelin 1. And as a result of that release and the receptor activity, we can get changes to the vasculature, to within the kidney that promote proteinuria, fibrosis, and glomerulosclerosis, as well as inflammation, that all lead to chronic kidney disease. So the signals for these agents look promising in terms of additional things we could offer patients. And so where this is all leading to is we have now our risk equations available for both kidney and for the heart that defines what risk category a patient is in. And so they might be in a moderate or low risk category, illustrated in green here. And we might offer these patients dual therapy such as RAS blockade and SGLT2. That's a current standard of care. And as they progress to intermediate to high risk, they might be offered another agent for triple therapy, and this might be something like a mineralocorticoid antagonist or the non-steroidal mineralocorticoid receptor antagonist, finerenone, and the GLP-1 agonists, particularly if they're diabetic and overweight. But there's increasing evidence about just the benefits of using it if they're overweight. And as we move to the very high risk and high risk category, these patients may be on 4 drugs. So you can see an analogy here to how we arguably used to treat arthritis with a number of medications depending on risk. And for heart failure and post-MI, get put on a cocktail of drugs to help reduce the future risk. And so now we have that framework for preventing the progression of kidney disease or slowing it. These are the two kidney risk equations. One is simply kidneyfailurerisk.com. I encourage you to do this for yourself and maybe for your loved ones, just to see how that works. There's another one from the I believe this American Heart Association that looks at another prevention calculator for heart and kidney disease that's also quite useful. A talk like this would be remiss if we didn't talk about sick day rules for medications. We're talking about a strategy to reduce the decline of kidney function over time. And a lot of those medications, if the patient's dehydrated, could pose harm to the patient in the immediate future. And they could get an acute kidney injury if they continue these medications during that time. So a patient's sick, has a flu or diarrhea or and some dehydrating illness where their vasculature, their volume is reduced. And it's in that setting that continuing to take certain medications will set the patient up to have an acute kidney injury, which is important of its own, but one acute kidney injury puts at a greater risk for having another one and so forth. So preventing the first one is important if we can, and preventing future steps. So this requires us educating the patient, giving them a list of pills to stop if they get into the flu-like situation or diarrhea, and identifying which ones to stop and actually stopping them. And once they've recovered, it's important to restart these medications so we can get that long-term benefit of reducing the decline of kidney function. On the BC Renal website, we do have a page that can be given to patients that explains what medications are important to stop. And on the left-hand side is the mnemonic SADMANS, which includes diuretics, ACE inhibitors, ARBs, the non-steroidal anti-inflammatory drugs, SGLT2 inhibitors, and as we move forward, others might get added to that list. But just to give you an idea, that patients need to understand this. And if you see a patient having an ACE or ARB stopped or SGLT2 stopped because of a rise in serum creatinine, it's important that be evaluated again to see if they can be restarted to get that long-term kidney protection, because they're already identified as being at risk for a more rapid progression of kidney failure. And so this speaks to medication review. And in the middle of this graphic is the CKD patient. And we want to optimize the medication impact. So add the drugs to the patient's regimen that will give them the best benefit. And this might be adding several drugs, as I've just described. Minimizing the medication-related problems, adjusting doses, switching to a different medication, et cetera. And almost more importantly is coming to a medication agreement that the patient's willing to take these and will take these. And starting off with just even obtaining an accurate medication list or a best possible medication history as a cornerstone to all of this work, and then engaging others in the medication review. So really, in summary, it is a new era for kidney health. It's an exciting time, and the evidence of benefit using multiple drugs is accumulating. The SGLT2 inhibitors, particularly the dapagliflozin, because it's now generic, should be part of standard of care. And finerenone may become a useful strategy where spironolactone cannot be used, or as evidence of additional benefit accumulates, that finerenone may supplant or become a standard of care. And certainly GLP-1 agonists do have a role to play in um, both promoting heart health, but slowing the progression of kidney disease, as well as we may see that the endothelin-1 antagonists come to Canada in the next 5 years. And as large-scale trials are done, adding each of these agents to standard of care and maybe becoming standard of care will further define just uh, that how we're tackling that residual risk, and we might get it down to a point that a good number of people will actually avoid going on to dialysis. That's the hope. And reducing the decline of kidney function is good for the patient, good for the system, and good for the planet. But we have to always keep in mind and educate our patients that sick day management is very important. And I'll leave it at that. And if there's any questions, I'm happy to take them either by uh, in the chat, or if you want to ask questions in the Q&A. I'm here to answer your questions. Thank you.
Like we got one here. Um, is there any benefit for an early renal non-dialysis patient to get on GLP-1 inhibitors if they are not obese and not diabetic?
Yeah, thanks for that question. I think we may not know the answer to that yet. Increasingly, I think cardiologists are interested in GLP-1 agonists. Um, there is a side effect, obviously, of losing weight if you're at weight, at an ideal weight. So we have to, and as you escalate dose to get the benefit of the drug, you also escalate side effects, which may be for someone who's not diabetic and not already at the goal weight may be unacceptable. So that might be a difficult sell, but I don't think we have the evidence yet to make that standard of care or make that recommendation. See another question. Mentioned sick day management is critical in CKD therapy. Could you elaborate the recommendations and patient counseling strategies pharmacists can use to effectively manage medication interruptions during acute illnesses? So you may not be aware the patient's got diarrhea or the flu or dehydrated, but if any patient comes seeking advice of an antidiarrheal medication, or they looking for some treatment for flu, it ideally would be nice to look at their profile if they're a patient of yours, or look on PharmaNet to see if they are prescribed any of the medications in the SAD/MANS mnemonic, and have that conversation with them. So they may not identify as being a kidney patient, um, but if you can identify those patients, and as you know, kidney care clinics have been asking pharmacists to put a little note into PharmaNet about kidney patient, please consider dosing, some language like that. And that might be a trigger if you look in PharmaNet to advise the patient, but also to have a conversation around once they feel better, once they're rehydrated, to reinitiate those medications. And uh, it would be nice to advise them to chat to their doctor around restarting the medications, just in case it's prolonged illness. We might have to retitrate. Uh, do these recommendations apply to post-transplant patients in preventing failure of transplanted kidneys and preserving function? Yeah, uh, I think all of these apply. That the new kidney, now the patient's immunosuppressed, but really all the same logic applies to these patients. In fact, they might be at increased risk depending on their reason for transplantation. Uh, So we have to pay attention to that. Sometimes it's a hereditary disease, polycystic kidney disease, something like that, that um, may be accompanied with um, other aspects, hypertension, et cetera, that might lead to that decline of that kidney that's transplanted, diabetes and so forth. So it becomes as important, if not more, to take care of that kidney. Any other questions? All right, you have my email address there, and I encourage you to go run through those kidney failure risk equations. Uh, and if you don't have your own laboratory data to run through them, just try different values that you can put in there, just to get an idea of the equations that we will uh, put patients' parameters in to look at risk. Um, Another question, in your opinion, what are the next significant developments or ongoing studies in pharmacotherapy that could further impact clinical practice and patient outcomes in chronic kidney disease? I think, we're in the era where we're getting larger scale studies. And just as in cardiology, over time of 20, 25 years, uh, as something demonstrated an absolute risk reduction of 1 or 2%, it became standard of care. And so the next study would use that therapy plus another one. And over the course of 20 years, we've been able to reduce um, the cardiovascular disease endpoints by about 20%. So I think we're seeing the same thing in nephrology. So as we establish now that SGLT2 inhibitors are the standard of care, we'll have large-scale trials to further figure out just the further absolute risk reduction we gain by using these newer strategies. And through that, they may become standard of care. So I think that's the thing to look out in the next 5 to 10 years, just how impactful the additional of these therapies are to whatever will be the standard of care studied in those trials. And I think we're close to end of time. I don't know if anybody else has any questions. Once again, you have my email there. If you have any questions, you can just fire me an email if you think of something else afterwards. Always available to answer your questions.
Yeah, thank you very much, everybody, for attending. This will be the recording will be put up on our YouTube here in a little bit as well. So we hope to see you guys at our next webinar coming up as well. Thank you very much again.
Thank you, everyone.